But our next wonderful speaker is Dr. Erere Otrofanowei, who is coming from Nigeria. She's a senior consultant dermatologist at Lagos University Teaching Hospital, as well as a senior lecturer and clinical researcher within the Department of Medicine. She has many areas of interest and expertise, and she has been very involved in speaking in multiple different societies. And we're delighted to have her talk today about the accessibility and affordability of emollients and atopic dermatitis in sub-Saharan Africa. So welcome. Thank you so much.
Good morning, everybody. Thank you for saying my name right. You did fantastically well. Very happy to be here. Very grateful to Claire and Esther, who have made me feel like I'm all that to be here. And I'm hoping that you take something from this presentation. So I'll be reporting on behalf of the African AD Working Group, as it were, something that we did. I'm affiliated, like she said, to the College of Medicine, University of Lagos, and the Lagos University Teaching Hospital in Nigeria, the foremost, most populous country in Africa. I have nothing to declare. I just came from overseas and I didn't declare an immigration either. So look at this as we're talking. Imagine a patient coming to you and after all the history, they say, oh, you have atopy, and they're like, ectopic? What do you mean? What does that mean? Atopy, what's that? And then you go ahead and explain atopy with all the genetics and environmental, and they're like, please, doctor, we're Africans. AD is for white people. Dirty know they kill African man, which means a bit of dirt and uncleanness wouldn't really hurt you, because we're supposed to be tough, you know, the African. Some people think that Africans still stay on trees and things like that. Some people still think that way. So is it a scoff at or a nod at the hygiene hypothesis of AD? Something to think about, okay? That's a patient. You can see him struggling. So whether a pediatric patient or even an adult patient, this is the sort of thing you need. And at the end of the day, sometimes it's a very simple thing, because while we can change the genetics and all the other problems with AD, we have something simple to do. So a bit of background. Back in 2019, at the ISAD meeting in Geneva, they thought to focus on AD in sub-Saharan Africa. And after all the talks and discussions, some of the members are here, they thought the survey showed that, okay, in trying to even manage the care, whilst we're still trying to find out a lot of things, what do you need the most? Everybody knows that we use corticosteroids, but then emollients are very important. The baseline for all the different data, all the different guidelines, emollients are baseline. And it should be simple, because we're now AD is doing biologics and therapies and so many things, but we're still saying emollients. So at that meeting, this was the current situation, that we have few data about African skin available, because very few of them are published. We have very few dermatologists. Some people have spoken about that earlier in the session. And in Madagascar, for instance, they have one dermatologist to 2 million people. There's no way they're going to work it out. And we have an increasing prevalence of common dermatosis, especially amongst pediatric population, and yet access to medicine is limited. So fast forward from 2019 to 2023, at the ISAD meeting in Gdansk, Poland, we had a round table, as it were. There's no table there, but you can guess what I mean. And the African dermatologists started to speak about the problems that they had. These were supposed to have been worked on from 2019, but of course, COVID came with all its shenanigans and some things took over. What did we find out? Problems, the magnitude of problems, the solutions. There were so many things, from traditional problems, practices, herbalists, you know, cultural solutions, medical dermatology, or rather the medicines that are there, and even the challenges. And so you move from the traditional practices where we're trying to even change what they think. Instead of using herbals, use Vaseline, use things, we have all that problem. So a myriad of problems. Where do you want to start from? Research and awareness, too many things. So we thought from Gdansk then, after we had the first meeting, some of the members are here, we translated to a WhatsApp group where the African dermatologists who are particularly interested in AD came together. Some of us were championing the fact. And we did a survey, presented some of it in Doha. So I'm going to be talking a little bit about what it is that we found out. So this is the African AD Guidelines Working Group. Of course, there are more of us now, but this is how we started. The simplest thing to do, let's take the low-hanging fruit, So emollients. 16 sub-Saharan African countries, members from there. Actually, we're 15 because Tunisia is not sub-Saharan, and Tunisia was one of them. So you can see Tunisia is up there. The rest of us are down there. From Nigeria, Madagascar to Southern Africa, people came together. And we had so many meetings back and forth. We had surveys, we put questionnaires out there. Everybody had plans. What is it that we're going to do? You think 16 out of how many? Well, that's about a third of all the countries in Africa. But it was a very well representative thing. So you can see the spread. That's why that slide is there. You can see the spread of it. And if you think about 3 of the countries involved, make up about what? Over 100 million of the people. So yeah, I think we can say we're speaking for Africa as it were. The available medications that we agreed, or available emollients, let's start with emollients. Everybody said, yes, they have shea butter. Everybody says, yes, they have coconut oil. But what shea butter do you have? Is the shea butter in Madagascar the same as the shea butter in Nigeria? Is it the same as the shea butter in Mauritania? And is anything being added? Who's making it? How is it being made? Where is it? How is it being stored? You know, so when you have diversity in all of these things, then you can't really speak as to what's exactly the quality and is it giving everybody the same thing. But at least we all have shea butter, so that's a plus. Now, is the shea butter being used? Or is the coconut oil being prescribed by the dermatologist, few and far as they may be? Because of these problems, some will say, this is not what we want to do because we can't trust what it is that you're giving. So what about the industrial emollients? What is happening with those industrial emollients? You can see a snapshot. Almost all the countries have imported emollients. CeraVe, well, I mean, they're sponsoring this program, so hey, good kudos. You know, we have topic cream, we have everything. And so many of these things I'm sure some of you are using here. But by far and large, everybody was using Vaseline. So let's look into Vaseline. It should be easy enough, right? Just give Vaseline. But is it? In Nigeria, that small tub of Vaseline costs 3,300 naira. That seems like a lot until you convert it to dollars, then you'll see what it is. Is it really a lot? It might be a lot, depending. That same size is about $48 on Amazon. If you checked in South Africa, it's about 65 Rand. And then in Madagascar, that same size costs about 200,000 plus Madagascan Erere. That sounds like a lot of money. So I asked Google, what exactly is 200,000 Erere in USD? It's about $42. Is that a lot? I think it is for 450, especially when you consider, according to this, the practicalities of using that tub of Vaseline on the patients. So I think it was Carsten Floor before they had said that an adult with AD will require about 400 to 450 grams per week. But something that was done again with Talent Hive and the EML writing group, I was a part of it, but it's reduced. I mean, we sort of checked it out and it's about 70 to 140 per week. Having said that, in a month, how much of that would you use? And then for what body surface area? How much of it can you get? So just to give you a context, exactly how much can be done. So these are patients of mine. This is an adult with AD. Acute, the video showing very bad, has scratched herself from now to, and this is not a poor patient. Look at all the post-inflammatory hyperpigmentation that comes about all over the body. So we're just showing you parts and it's all over. How much of Vaseline does she have to use to do a wet wrap if necessary sometimes? This is another patient who is not, so that wasn't the private hospital, this is in the teaching hospital. And you see all that AD flares and, you know, how long are you supposed to use this for? How much and what frequency? So we took a poll, 100 ml of Vaseline in the participating countries. So let's stay on this slide for a bit. Some of the minimum wage, I can't even speak to it because it's so much. So let's start with Tanzania. Minimum wage, 140,000 Tanzanian shilling. Now, remember that minimum wage is for the lowest people, so simple domestic workers or, you know, artisans, as it were. And that's $1 to over 2,000, almost 3,000, 1 to 3,000 shillings. So that's how much it is. And the minimum wage, so it costs 9.7% of their monthly salary to buy 100 ml of Vaseline. 100 ml of Vaseline is not going to take care of the patient for 3 days, technically speaking. So this is the simplest thing. So if you look round, just go scroll through. I think the best country there is probably South Africa, which is about 2% of the monthly salary. Some is over, I mean, look at, I think it's DRC, Congo, how much it would cost them to buy 100 ml of Vaseline. Emollients are the lowest hanging fruit. Emollients are the baseline for everything. We have more problems to think about in terms of the genetics and all the other research and all the things we need to do. And we know that managing AD right now is talking about biologics, and we're talking to dupilumab, and we're still looking for Vaseline. So going forward, that's Vaseline. What about democorticoids? Tacrolimus steroid sparing, because for those who know, they are very afraid of using corticosteroids. So I didn't even bother bringing steroids. Tacrolimus, it costs for the 10-gram tube about $5 in some countries. In some other countries, you can't even find it to buy. Methotrexate is the one DMARD that is actually available all over Africa, and at least in the countries of it, and it's cheaper when you think about it. Now, $0.15 for tablets. More often than not, you're going to give the patient maybe like 10 milligrams per week and all of that. Azathioprine is a bit more expensive, not as available in some places. Cyclosporine is a bit more expensive, not as available. By and large, the point we're trying to make is that, yes, we have these medications. Yes, they may be available in some countries, not as accessible because of the cost. So even if the low-hanging fruit, which is the baseline of emollients, we're finding it difficult, it makes you wonder, how are we really managing these patients? But it's important for us to actually do this work, because then we can progress. So what do we do? Do we think along the lines of making it cheaper? These are important things. Or do we think about what it is that is available to us, the shea butter and coconut oil that was available in all countries, and see how we can standardize that, as it were, to move forward? Luckily, in the first part of this thing, we had been talking about training of dermatologists. And in that survey, we had people say exactly what it is they do. So we are moving, thanks to things like GLODERM and ILDS, we are moving from not having the dermatologist to actually improving on that nice crop of specialty. But how are they able to really give their expertise if access to the things that they need is a problem? So all the training programs, I just put this slides for us to know that in Nigeria, somehow I think we like to suffer. Ours is like the longest, but I'm hoping that, I don't know, well, I've already gone past it, so I won't have to go through that again. South Africa has their training, and everybody goes through the same thing, like I think most of you do here. So that's actually good, but it's just buttressing the fact that the training is good, the expertise is good, but how are we able to really give what it is that we have to give? So in summary, I've just tried to show that we do have emollients, but most of it is imported. And that's the training of the dermatologists on ground, because they understand the importance of having standardized things. So you can't just say, oh, use what is available. We do have a negative impact of that efficacy of treatment because of the high financial burden. We know that traditional emollients and local manufacturing of effective emollients will improve treatment outcome. We're hoping that we can assess it better. And I think I want to say again that, yes, African dermatologists are well trained. So I'm acknowledging the African AD Working Group. Professor K. Kaites is here, the African Society of Dermatovenerology, the ISAD, some of my younger colleagues who I'm hoping to join GLODERM very, very quickly. And Lagos is welcoming you all to our Dermatology and Global Health Bridging the Gap conference coming up in June this year. It'd be good if you can come overseas to my side of the world. Thank you all for listening.